So, hello everybody, dear colleagues in Pakistan. It's my great pleasure and an honor to talk today to you on the topic of psoriatic arthritis, the current management strategies and the role of the IL-17 inhibitor Secukinumab in psoriatic disease. So my name is Frank Behrens. I'm a rheumatologist by training at the Goethe University in Frankfurt, Germany, and I'm leading drug development and clinical research within the Fraunhofer Institute for Translational Medicine and Pharmacology. So here are my disclosures. Here are a disclaimer from the company who is sponsoring this meeting today. Yeah, I think most of you are familiar with psoriatic arthritis. So we prefer nowadays to talk about a psoriatic disease, not arthritis, taking into account that this kind of a disease is very heterogeneous. So we have different kind of musculoskeletal inflammation, in addition to the skin and nail inflammation, which is illustrated here. Of course, we have in some cases typical peripheral arthritis with a plaque psoriasis, but sometimes we have extra articular musculoskeletal inflammation like dactylitis and enthesitis, but also spinal involvement. And enthesitis is a crucial thing in psoriatic disease for many, many reasons. On the one hand side, for the reason regarding pathophysiological concept, but also to better understand what drives the burden of the disease in an individual patient with psoriatic disease. And it's not only a heterogeneous disease by the phenotype, it's also a disease where we have several therapeutic options available in different countries across the world. I think in your country, you have the conventional DMARDs like methotrexate, you have the etanercept as a TNF inhibitor, you have a tofacitinib as a JAK inhibitor, and you have secukinumab available to treat your patients with psoriatic arthritis. We have several, let's say, recommendations from official organizations how to treat patients with psoriatic disease. And I definitely prefer to use a CRAPA recommendation. CRAPA means Group for Research and Assessment for Psoriasis and Psoriatic Arthritis. This group started to work together as rheums and derms and other healthcare professionals when Philip Meese in US made the first study with etanercept and infliximab in psoriatic arthritis, and we in Germany, for example, made at that time a study with leflunomide in psoriatic arthritis, and then the idea came up to better collaborate across the world on the psoriatic disease to achieve improvement for patients in our routine care. And this was a starting point for the CRAPA. And CRAPA has built up different recommendations for treatment of psoriatic disease in the past. And this is the newest one from Laura Coates, published in 2021 in Nature Review, Rheumatology. And the main aspect how these recommendations were built up is that we look for different domains of a disease who might be affected: peripheral arthritis, axial inflammation, enthesitis, dactylitis, skin psoriasis, nail psoriasis, and in addition, so-called associated diseases, which is uveitis and inflammatory bowel diseases, which all might influence the decision what kind of product should be used to treat our patient with psoriatic disease. And you see in all the boxes, the drugs or the mode of actions who have demonstrated evidence that it might work in this individual domains. And I think, of course, most of the patients, as we are rheumatologists, are starting having peripheral arthritis and enthesitis. And when you are in these different domains, then you have to think about whether a product is strongly recommended or only conditionally recommended or strongly against. This slide is also from the CRAPA recommendation in the Nature Review Rheumatology article. And you see that for all the different domains, peripheral arthritis, DMARD naive, peripheral arthritis, inadequate response after DMARD, peripheral arthritis failed a biological DMARD, axial disease, enthesitis, dactylitis, and so on. For all these, you can see in the different rows the different products who had either a strong recommendation or only a conditional one, or a strong recommendation against. For example, there's strong evidence out that conventional DMARDs are not working in axial psoriatic arthritis. So if you have a patient, for example, with an axial involvement, you can clearly see that axial disease shouldn't be treated with a conventional DMARD. You should directly go to a biological based on the study outcome demonstrating that it might not work in this condition. Let's start with the peripheral arthritis to look more deeper into this field, because this is the most common feature active in psoriatic disease in combination with enthesitis, and most of the data were generated in a typical clinical trial focusing on peripheral arthritis. This is why we have very good evidence for this kind of domain. Yeah, I think you are all rheumatologists, and you are aware how arthritis might look like. And this is a typical proximal interphalangeal joint arthritis, a PIP arthritis. And of course, normally you see a synovitis proliferating, having a lot of inflammatory cells included and inflammatory cytokines involved, a huge exudation, which means a lot of fluid in the joint, and you see it like this. And this might result in an erosive disease. And this is a typical feature for rheumatoid arthritis. In psoriatic arthritis, it might differ. In rheumatoid arthritis, you have this synovitis, this pannus, where TNF is a crucial cytokine within this pathophysiological process in a typical synovitis arthritis, which is typical for rheumatoid arthritis. It's different in psoriatic arthritis or in spondyloarthritis in general. Here you see it. On the left-hand side in this cartoon, you see a joint again, but you see what is marked here is the enthesial complex. It's not the synovial membrane in the cavum of the arthritic joint. It's the enthesial compartment, the tendons, the ligaments. All these are involved very early in psoriatic disease, in contrast to RA. And synovitis in psoriatic disease is often secondary and followed after enthesitis, tendinitis, etc. And this is also of importance because in this specific kind of musculoskeletal inflammation, not focused on synovitis, but on enthesitis and the ligament parts of the compartment of the joint, TNF is not playing the major role. It's mainly an IL-23 and IL-17 driven process, but not a TNF, because TNF is a typical, let's say, unspecific pro-inflammatory cytokine, which is generated later on, but not from the beginning in the specific conditions of psoriatic disease. And this is important to understand. We believe nowadays that IL-17 and IL-23 inhibitors changing the underlying immune processes, while TNF blockade is only a classical anti-inflammatory cytokine, which, if it is blocked, might not influence the overall underlying immune dysregulation. Yeah, why is enthesitis so important? This is outstanding work from Leeds in the United Kingdom, from Dennis McGonigal's group. Understanding that we have an anatomical neighborhood between the nail matrix and the flexor and extensor tendon of the DIP joint. Why is it so important? This helps us to understand why patients with nail psoriasis have a threefold higher risk to developing arthritis. And it also helps us to understand why typically in psoriatic arthritis, DIP joints are involved, while in RA, normally not. How can we understand it based on these findings and the anatomical sections? Yeah, you see that if we believe that enthesial compartments and tendon compartments are very early involved in psoriatic disease, but not synovitis, you can imagine that the DIP joint is heavily characterized by capsulars, by tendons, but not by synovial membrane. It's too small for a huge synovial membrane, while MCPs and PLP joints have a huge cavum, a huge space where synovial membrane is of more importance. And this can now understand why DIP joints with PSA are often involved, but not in RA. And you can see here, you can imagine if we have a nail psoriasis illustrated on the left part of the slide, immediately this inflammation can continuously proceed to the anterior compartment at the finger, and then making a step forward from a pure skin and nail disease towards to a musculoskeletal inflammation. And this can mimic in mice model as well. So if you have mice with a psoriasis and you induce arthritis in the specific models, immediately they start at the nail compartment and the DIP joints to get inflammation, while in classical collagen-induced arthritis model for rheumatoid arthritis, other joints are involved. And you can also see here, this is an example of fluorescence optical imaging, which is a new technique where you inject indocyanine green, and then you can immediately see this increased fluorescence marker as a sign of inflammation at the DIP joints in the psoriatic patients, typically at the DIPs, and later on only at other joint compartments. Having this in mind, the question is, what is the ideal therapeutic approach for our patients with peripheral arthritis and maybe enthesitis in psoriatic disease? And you are fully aware that etanercept with Philip Mees has demonstrated effectiveness in PSA, but also other TNF inhibitors like adalimumab is an ADEPT trial, infliximab, etc. And the problem is, based on the different clinical trials, that we missed in the past direct comparison. So if you ask me what is the best product for my individual patient, the answer is I have no clear answer, based on the fact that in the past we didn't have a clear head-to-head trials. What we had in the past was indirect comparison. Indirect comparison means you make a network meta-analysis like this, where you compare placebo responses to active and the delta, and then compare to different other products. But of course, this is a challenge because this is not a typical head-to-head approach. But nevertheless, you see on the left-hand side the so-called number needed to treat in this kind of indirect comparison. Number needed to treat means how many patients do I have to treat to achieve at least in once what I want to achieve. And you see the number needed to treat to achieve ACR 20 in Secukinumab on the left-hand side is 2.3, means in 2 patients treated with Secukinumab, at least in 1 I achieve what I want to achieve. The same is ATR 50, which is a higher hurdle of response. 3, if I treat 3, at least in 1, I will achieve with Secukinumab an ACR 50. And this is comparable to, for example, a TNF inhibitor like golimumab. You see, it's a little bit better than what I can achieve with etanercept. You see it lower down in the slide with ETN as an apparative. So this gives you a flavor of the effect size of Secukinumab Cosentyx in psoriatic disease, with this very impressive number needed to treat demonstrated here. But of course, what we want to ask for is show us a direct comparison between TNF inhibitor and Secukinumab or IL-17 inhibitor. So there are several randomized clinical trials, head-to-head trials of different companies listed here: Pfizer, Roche, Sanofi, Abbott, and sometimes people designing clinical trials in a way that they will never fail. You, for example, Abbott down here, you see 100%, which is a red bubble. They were successful in a head-to-head, means the product of Abbott or AbbVie wins against the comparator. In Novartis in 84%, so in some cases not. So Novartis was so, let's say, motivated to make a head-to-head trial with Secukinumab against a TNF inhibitor, which is adalimumab, in this case, to show effectiveness of secukinumab in psoriatic arthritis. And this was the EXCEED trial. So in the EXCEED trial, we have a primary endpoint after a year of treatment, be randomized and blinded secukinumab against adalimumab in a monotherapy setting. No one has methotrexate. It's a typical monotherapy. Patients failed a conventional chemotherapy like methotrexate, and then they were randomized to go either to secukinumab or to adalimumab. And to be honest, keep in mind that adalimumab is much stronger with respect to skin disease, for example, compared to etanercept, which is a TNF agent you have available in your country. So, and the primary endpoint was ACR 20, typical arthritis score after 1 year of treatment to see whether this is superior to adalimumab. And this is a primary endpoint. You see the red line is the TNF inhibitors, the blue line is secukinumab, Cosentyx, and you see it is as fast as adalimumab, and you can achieve at least the same range of ACR responses after 1 year. And you see the blue line is a few more percentages. It's above the red line, means there's a trend to have more responses in secukinumab compared to adalimumab for ACR responses in patients with active psoriatic arthritis. But it is not significantly superior, which was planned for the study. You see the p-value is 0.07 and it has to be 0.05 to be significant. But you see here, it is at least as good as adalimumab in psoriatic arthritis, focusing on arthritis. So if you go to ACR 50, it's the same picture. You are at least as good as adalimumab when you treat with secukinumab, with a slightly trend to be superior to adalimumab. And I come back to enthesitis because enthesitis is so crucial in PSA. So there are data out that patients with or without enthesitis are totally different with respect to burden of disease. So if you have a patient with 10 swollen joints and 3 swollen joints, of course, you would immediately recognize that 10 swollen joints is a more severe disease than 3 swollen joints, for sure. That's absolutely the truth for rheumatoid arthritis. In PSA, it's interestingly, if you have a patient with 10 swollen joints but no enthesitis, and a patient with 3 swollen joints but enthesitis, the disease burden is much higher in those patients with 3 joints plus enthesitis compared to 10 joints only without enthesitis. Just illustrating the importance of enthesitis for the well-being of our patient, for function, for burden of disease and loss of life quality. So here we compare different scores for enthesitis, the Leeds enthesitis index, LI, and the SPARC index at week 24 and week 52. And you see again in the trend, secukinumab seems to be slightly better. It's not a significant difference, but at least as good as adalimumab. And again, adalimumab is a more powerful product in spondyloarthritis, specifically in patients with psoriatic arthritis compared to etanercept. So let's move forward to the next slide. This is treat to target approach. Of course, we don't want to compare only ACR responses, because ACR responses are a delta, an improvement, which is great, but we want to achieve a specific target, a disease cause which is very low inflammation, very low involvement of musculoskeletal system. And this is MDA, minimal disease activity, or VLDA, which is very low disease activity. So maybe you are aware in MDA, we're looking for swollen joints, for tender joints, for skin disease, for HAC-DI, for function, for patient global, for pain, and for enthesitis. And you have to achieve 5 of these mentioned 7 domains, with only 1 active maximum enthesial site, 1 active tender or swollen joint, and almost clear skin, and pain, etc., should be very low. So MDA is a very well-controlled disease. associated with no risk for structural changes in X-ray and with no risk for cardiovascular events compared to a normal population. VLDA is mainly remission. And you see, again, at least as good as adalimumab, the Secukinumab data, and at week 52, slightly higher, 43 MDA percentage patient compared to 37, which gives you a flavor how it works. And if you look to low disease activity in a joint score and remission, you see that we have more patients in low disease activity and remission in Secu compared to adalimumab. This is only one head-to-head study, Cosentix, the Secukinumab study. But there is another one, the Spirit head-to-head, which is Ixekizumab. And Ixekizumab is an IL-17 inhibitor as well. And they made a different study design. They looked for patients who achieve both PASI 100. PASI is a psoriasis area and severity index, means a skin score, and a PASI of 100 means complete clear skin, plus ACR 50, 50% reduction of the arthritis score. And the patient were asked to have both simultaneously, and a simultaneous response of 50% in the ACR score plus a complete clear skin is more often achieved with the IL-17 inhibitor, Ixekizumab, compared to adalimumab. Of course, mainly due to the fact that they have a much better skin response compared to adalimumab. And keep in mind, etanercept has a much lower skin response compared to adalimumab, which would make these differences much higher. And they met it, though they have more patients, 10% more patients achieving both 50% joint reduction and 100% clear skin when treating Secukinumab and adalimumab, or treating Ixekizumab and compared to adalimumab. So if you compare both IL-17 inhibitors, on the left you see Spirit head-to-head, which is the Ixekizumab study, and right it's the Exceed study with Secukinumab. You see different outcomes. If you go clockwise, you have ACR 20, ACR 50, ACR 70 for the arthritis scores. You have the PASI and the MDA and VLDA, the combined scores. And on the left side, you have the enthesitis story. And you see the dark red, purple line is the TNF inhibitor, adalimumab, and the yellow one is the IL-17 inhibitor. And you see clearly that in all domains, the yellow line is at least as good as TNF inhibitor, but in many other domains, it is superior, specifically for skin disease and for other enthesitis domains, a trend to be superior. Gives you confidence that it works out properly. What about the JAK inhibitors? I think the JAK inhibitors, at least for psoriatic arthritis, has demonstrated in mainly two studies. So OPAL studies with tofacitinib and the select PSA studies with upadacitinib. And I think you have tofa available in your market. There are two limitations with the JAK inhibitors in daily practice. The one is it is only licensed and approved in combination with methotrexate, while the biologics work without. And the other one is that we have recently the information on a tofacitinib study against TNF inhibitors that we have a higher risk for cardiovascular events and malignancies in the tofa-treated population compared to the biologic-treated patient, in this case, the TNF inhibitors. So this leads to a kind of warning of the European Medical Agency, but also of the FDA, pointing out that these medicines, means JAK inhibitors, all JAK inhibitors, should only be used in the patients without any other suitable treatment alternatives, when they were older, when they had an increased risk for cardiovascular problems, those who were smoking or have smoked for a longer period of time, and those with an increased risk for cancers. Also, JAK inhibitors should not be used in those patients with risk for blood clots, thromboembolism, VTEs, and this gives us now the challenge that those drugs were only recommended for a small proportion of patients based on the fact that they demonstrated an increased risk for adverse events, specifically cardiovascular events and malignancies compared to biologics like TNF inhibitors. This gives us some limitations. And this was also reflected now by the CRAPA recommendation. You see here, JAK inhibitors should only be used with caution in those with elevated risk for cardiovascular events or congested heart failure and elevated risk for VTE. You see it on the right-hand side, this JAK inhibitor column here, which is also again listed in the CRAPA recommendation in the Nature Review Rheumatology article. Let's move forward to the axial disease. If you have axial inflammation in psoriatic disease, you have a challenge to choose the right product because, as I mentioned in the beginning, clear evidence that conventional DMARDs are not working in axial disease. And in the past, we believed that all the biologicals will work, but it's not the case. This is an example for an IL-23 inhibitor, risankizumab. And you see different doses of risankizumab and placebo. You see different outcomes, biomarker outcome, imaging outcome, and clinical outcome. And you see in all the domains, red means worsening, blue means improvement. And you see a very, let's say, colorful picture, unorganized, means at the end, we have no effect of the product compared to placebo. This was surprising to us. And then the question raised whether the axial involvement in PSA differs from ankylosing spondylitis or axial SPA. And Novartis made a trial with secukinumab specifically in PSA patients with axial involvement. You see here's a study design, very straightforward study design, placebo, 300 and 150 sub-Q secukinumab. And you see here the outcome, which is the ASAS 20 from this so-called maximized trial. And you see a clear, significant effect in the ASAS 20 response of secukinumab compared to placebo. And this is the only available study in PSA axial patients demonstrating effect of secukinumab in the specific domain. And this is reflected in all recommendations. This is a EULAR recommendation from the European League Against Rheumatism. And you see if you have a predominantly axial disease, no DMARDs are recommended. Conventional DMARDs go directly to B DMARDs, either TNF or IL-17. No other products have demonstrated proper effectiveness in these domains. We are rheumatologists. Should I take care about the skin? And my answer is yes, because the skin disease in this psoriatic condition is of importance for our patients. And if we as rheumatologists want to achieve a proper response in our patient cohort, we have to take care of the skin as well. Of course, you can argue it doesn't matter whether secukinumab is superior to a TNF inhibitor in skin, because mainly I'm focusing on arthritis, but I will show you why it is of importance. So this is again the head-to-head study of secukinumab Cosentyx against adalimumab as a TNF inhibitor, and this is PASI 100. Remission of the skin, no plaque anywhere. So complete clear skin. And you see that you can achieve it in nearly half of the patient with secukinumab and only 30% in adalimumab treated patients. In psoriatic arthritis patients population, it's not a skin psoriasis study, it's a PSA study. And why is this important? And this is a very interesting slide, a kind of, let's say, flying carpet. I will guide you. We go to the right part of the figure. So this is the improvement in life quality, the EQ5D. So the higher, the better is the life quality. And these are the patients at the starting point at baseline. The DAPSA on the right-hand side, this is a pure arthritis score. PASI is a pure skin score. So, and if you treat a patient with any modality, and you only achieve, in a PSA patient, if you only achieve a proper response in PASI, the life quality increased only by this. That's clear, to be honest. A PSA patient, the skin is great, but arthritis is still there, is not happy for sure. And this is what we have in daily practice in our cohorts. So we have a DAPSA scoring, means a pure arthritis score. And if you have a 100% response on arthritis, this is the increase of life quality you can achieve. It's roughly in the middle only and not at the top. Why? Because the remaining skin is influencing heavily the life quality. So you can only achieve a very normal life quality if you have both a PASI response, which is proper, and adaptar arthritis response, which is proper. This is why we have to take care about skin revolvement in our PSA patient as well. Yeah, I think in summary, hopefully I have illustrated that IL-17 is a key cytokine in skin disease, in musculoskeletal inflammation, in axial and enthesitis. Why it is so important to target it and gives you some superiority compared to other mode of actions in this specific conditions. Yeah, these are the key inhibitors of different cytokine pathways demonstrated effectiveness in randomized clinical trial. And I learned that you have available only the TNFs and the Secukinumab. All these are 23 or IL-17 inhibitors, the modern biologic treatment approaches. And you see Secukinumab has demonstrated efficacy in phase 3 studies for psoriasis, for PSA, for axial SPA. But of course, you have learned in IBD, inflammatory bowel disease, IL-17 will not work properly and should therefore not be used in IBD patients. With this, I really like to thank you for your attention. Sorry that it's only a virtual presentation presented by me. Greetings from Frankfurt in Germany, and I wish you a very great meeting, and I'm happy to answer some questions, and I will check out the chat and will look for the questions and address these questions properly.